And so the recording will also be posted to our OBHI YouTube channel, but live attendance is required to receive a CEU. And what I need you to do is to put your name, your credentials, and your role in the chat. And that is how we will be taking attendance today. So please make sure that you put those things in the chat. To claim your CEU, you need to complete the survey that PSU or that we will be sending you. And PSU will also be sending out a survey for those who just want a certificate of attendance and to give us feedback on our trainings. So you will receive follow-up email from us that has the recording, the slides, and any materials that Dr. Drago wants us to send along. And then also you'll get an evaluation email from Portland State for you to fill out. Okay. So most of you know the Behavioral Health Initiative started in 2015. You have two specialists, myself and Angela Jensen, for Josephine County. So we provide complex care consultations. We do workforce development trainings like this, and we do lots of collaborations and coordination with folks within the county and across the state, supporting older adults and adults with physical disabilities. So this is our website if you want to check it out. And then we have two more trainings this month. We actually have one tomorrow on suicide in older adults. And then later in the month, we have Hospice 101 for behavioral health. And so this was something that case manager kind of brought to us, and we felt like it was a needed thing for people to understand kind of the basics of hospice and how hospice can support, and we can work with hospice around more marginalized populations that we all work with within our mental health world. Okay, so I'm gonna stop share and let Angela introduce Dr. Drago.
I am thrilled that we are able to bring Dr. Drago to you again. And because I'm not a morning person, I'm going to read her bio because there's a lot to unpack. So just in a very condensed little blurb, Dr. Drago received her fellowship in geriatric medicine in 2015 at OHSU, Oregon Health and Science University. She joined the OHSU Division of General Internal Medicine and Geriatrics in 2015 to develop and run the inpatient geriatrics program, providing consultative geriatrics care for hospitalized older adults in partnership with medical and surgical providers. She served as medical director until 2021, when she transitioned to the director of quality for inpatient geriatrics. Dr. Drago's academic interest is in systems improvement of the care of hospitalized older adults. She has worked to improve the care for adults with delirium, standardized safe prescribing practices, and enhancing the care of older adults with acute fragility fractures. She leads an interprofessional team of experts in expanding OHSU's age-friendly health systems program and serves as the medical director for OHSU's Episodes of Care value-based care program. Dr. Drago, we want you to have as much time as possible. Thank you for being with us today. I'm going to turn the mic over to you now.
Well, thank you so much, Angela and Angela, the dynamic duo. I am honored and just absolutely tickled to have some time with all of you today. I know through personal experience with patients that all of you, as I was watching your roles, names and roles come through on the chat, I was thinking this is a very busy group of people that has some very full plates. So I really appreciate you making some time to hang out with us. The session today is really going to focus in on pain, pain assessment, how it presents differently in different populations, not just older adults, but particularly those that are cognitively and communication impaired, which, as I'm sure you all are well aware, can affect people at any stage of life, but is certainly more common in later life. And talk about medication misuse in this population, how it can look, some of the risk factors that I'm sure will not be a surprise to anyone on this call. And there is a lot of material in these slides that that I may breeze through, just full disclosure. But as you get the slides, please, in your copious free time, please feel free to go through them because I also have some material in here on different medication classes that even though the bulk of you may not be prescribers, you certainly are seeing clients and patients that are being treated with these medications that can oftentimes get older adults into trouble. And vulnerable patients into trouble. And you and your teams may actually be the first people to recognize some of that trouble. Which is why that is in there. And then some of the recent data on strategies like Tai Chi and massage, which really anyone, you do not need to be a physician or a provider or a prescriber to talk about those practices with clients that can actually be really beneficial. I could talk all day about this, but we have an hour. So I'm going to try to hit the high points, but just know there's more Easter eggs in the slides than we will have time to go over today. I always like to start here with disclosures and just being very transparent about my connections. I have been at OHSU for 13 years and I'm an academic geriatrician, which means I have no connections to big pharma or medical industrial complex. I do do some nonprofit board service in the Portland metro area, but I don't receive any financial remuneration for those services, and I'm not even going to mention those organizations today. I have received some one-time payments, honoraria, within the last year for expert service as an expert advisor to the Institute for Healthcare Improvement that runs age-friendly health systems, which I would love to come back and talk to you about in the future. Today, these are essentially the same learning objectives and goals that were on the session advertisement flyer, so none of this should be surprising. We, again, are going to talk about pain assessment and the sort of epidemiologic experience and burden of pain and discomfort in this population. We're specifically going to carve out those that are cognitively and communication impaired. This is the part of the talk where I like to sort of drop the Easter egg that when I say cognitively impaired older adults, I'm actually referring to kind of a broad net and a big umbrella that includes more than things like organic dementias or TBI survivors. That this broad net can also include people who are stroke survivors, delirium survivors, those that may be on the autism spectrum that live with intellectual or learning disabilities, or what we now call neurodiversity. Tools for pain management, and then some elements of successful treatment planning. So I want to start with this little thought exercise. No need to put anything in the chat. Just sort of, as you sip your coffee, think about this true or false statement. Pain is a normal part of aging. And I'll be even more specific. When I say normal, what I mean is physiologically normal. So just an inherent biologic expected part of an aging machinery. That is just like hair turning gray or white. True or false, do we think? I just turned 40 this summer, and I swear to God, I woke up on my birthday and my back was sore, and my back has been sore ever since then. So I've been tempted to change my thought on this and say it's true, but it is actually not true. Pain is not a normal or expected part of aging. And the reason I like to start here is to level set for all of us, because I'm sure at times in our own lives, the lives of our loved ones or our clients or people in our orbit, we have heard people say things like, oh God, I'm 90 years old. Of course I hurt all over. I've even heard doctors say that to patients when they have come in seeking help or thoughts on like, why does my body feel this way? And this is a really common misperception, along with other misperceptions about aging, that it's all fragility and it's all downhill. Um, the kicker is that more commonly painful conditions are just more common with age. So thinking about things like arthritis, even visceral, blood and guts diagnoses like cancer, autoimmune diseases, heart disease that may lead people to have angina or exertional chest pain when they're moving around. Those are all very common in older adults. And so that's in part why we believe this misperception. Pain is, though, incredibly common in older adults. These are lots and lots of epidemiologic numbers from sort of the early 2000s. We know 2/3 of older adults living in the community report living with persistent pain of some sort. And this could be anything from achy back, achy joints, arthritis, to like complicated cancer or neurologic pain. This is true of people living with cognitive impairment. In these studies, it was mostly dementia, those living with cancer, except the vast majority never receive any sort of advice or counsel on non-drug interventions or practices or strategies that they can use to help feel better. And even up to 1/3 never receive any drug therapy from their providers to treat their symptoms. And that odds of that are even lower for the oldest old in our community, those that are over the age of 85, those living with cognitive impairment. And we know more about the dementia population here than we do other cognitively impaired folks. But I suspect, as do most people, that this is not limited to just people living with dementia. And then those that are experiencing some form of physical restraint, which still does happen definitely in the hospital, but also in long-term care. That presence of physical restraints is associated with a lower odds of being treated for physical discomfort. We don't know exactly why this is, but there are proposed reasons that are down here listed at the bottom. And I'm assuming none of these are really going to strike anyone as being totally out in left field. We all know older adults that in our lives, maybe grandparents or aunts or uncles or parents even, that dismiss their own symptoms. That's my dad, who even had shingles and didn't call his primary care doctor or didn't call his daughter. It was just so painful he couldn't walk and decided to live through it. There's also internalized ageism, meaning older adults just also believing that I'm old now, so I have to live with this, in addition to ageism from healthcare professionals. I touched on this briefly before, but when we use the term cognitively and communication impaired patients, it's a broad tent that does include people with dementia, Parkinson's disease, delirium and delirium survivors, lots of neurodegenerative diseases, TBI survivors, severe persistent mental illness, intellectual disabilities, aphasias, autism spectrum disorders, and more, and on and on and on. I do expect that some of you may have practices that cater more maybe to a younger audience, or maybe certain diagnoses or niches listed here, maybe different folks living in different environments. Totally fine. Even if you work with a mostly 40-year-old or midlife population, chances are you are involved with some patients that would fall into this big tent. That are living with some sort of communication or cognitive challenges. And the reality, too, of a lot of our health system successes over the last 50, 70 years is that folks are not dying of cancers or heart attacks or strokes that would have ended their lives much earlier, like they did decades ago. And so we actually have a growing population of 70, 80, and 90-year-olds that are living with severe persistent mental illness. I have schizophrenic patients that are in their 80s now. And that is the consequence of success, is that more of these patients are surviving into phases of life where they deal with more fragility, cognitive and communication fragility. The reason I like to dive into this a little more deeply is that these patients experience the same degree of pain and discomfort as cognitively and communication intact patients. We used to believe, it was a very common belief in medicine, that among doctors, that people with dementia could not feel pain. And when I say common, I also mean recent, because that was a recent teaching point that physicians taught medical students as recently as like the 90s. And so there are still people, providers and caregivers out there that believe that people with different brains don't feel pain the same way as people with sort of traditionally normal brains. And that could not be further from the truth. Human beings are human beings. We have all the same human experiences. We just manifest them differently. There's also lots and lots of research coming out about the prevalence of chronic pain in conditions like dementia and other neurologic diseases. Long story short, this is a study of studies, a meta-analysis, showing that across the different types of dementia, about 50% of those patients live with some form of chronic discomfort. 50%, that's huge, humongous. And there's even interesting research that I'm sure we'll hear more about over the next few decades that as we learn more about Alzheimer's pathology with accumulation of those abnormal proteins in the brain, that there actually is an inflammatory cascade and lots of sort of brain on fire and metaphor, analogous things happening in the brain with Alzheimer's disease that may actually cause a chronic pain syndrome from the brain, similar to fibromyalgia and other CNS pain conditions. And so there is so much that we don't know about this population and what they experience, both related to their diagnoses and related to maybe other conditions that they may be living with. Knowing all of that, pain manifestation, the way it looks and the way it presents, both to physicians, but also just in daily life to friends, family, care teams, caregivers, can be a very heterogeneous experience. One older adult's experience of pain is not going to be the same as the next one. And so I like, in true Dickens form, I call this point a tale of two patients. These two ladies right here both have the same list of conditions. They are both 88 years old. They both have the same stage of osteoarthritis of the knees. The x-rays look exactly the same if you put them up right next to each other. They both have osteoporosis, brittle bones, and have both had compression fractures of their spine, so squished vertebrae in the spinal canal that has changed the way their back is structured. The woman on the left here in the wheelchair with the attendant lives with daily constant discomfort in her legs and her back that is so significant that she lives in an adult family home and receives ADL assistance from the caregivers there and is mostly homebound. The woman on the right, same age, same diagnoses, lives in the community and is able and excited to mall walk 2 to 3 days a week with her friends to keep herself active. And so diagnosis, list of diagnoses, age does not crosswalk directly over to what the patient experienced, what their lives are like, and what the impact or extent of limitation or effect the discomfort might have. So geriatricians are fond of saying, if you've seen one older patient, you've seen one older patient. I believe the same is true with older adults with chronic pain. If you've seen one older adult with chronic discomfort, you've just seen one older adult with chronic discomfort. So how do we investigate this? What do we do? I'm sort of going to blow through this. All pain is not created equal. There are lots of different types of pain. This is what we as medical providers and prescribers are trying to think through as we are assessing patients, because medications and different therapies work differently for different conditions. So diagnosis, not just a descriptive term like chronic low back pain or neuropathy. Those are starting points. Those are not ending points for us. Getting a diagnosis is really important because that can crosswalk over to different treatment modalities. there are two really big ways, two big categories of ways that pain manifests in older adults, the physical signs and the behavioral signs. These are in addition to the older adults that will come in and say, hey, we need to talk about my knee because it's really bothering me. That definitely still happens. But you will see, and chances are you have seen amongst your clients, some of these physical and behavioral signs that maybe were misinterpreted, maybe led kind of down other paths without thinking about like, they may actually be in some discomfort. The couple that I like to call out here under physical signs, falls and functional impairment can actually be a sign of persistent discomfort. We've actually seen this at OHSU amongst our trauma patients that come in after a fall with an injury. That as we talk to them about like, what has been going on, let's dissect the fall, let's figure out what caused it, and what we might be able to do about it. We actually hear from patients a lot about worsening discomforts, worsening pain in some form, affecting their gait, affecting their balance, and affecting their energy, and then ultimately leading them to fall. So I did see there were a couple of maybe APS investigators. I was watching the chat in this group. Welcome, we love you. When you are assessing patients, this may be a common observation that people are sort of self-neglecting or failing to thrive in an independent environment, thinking about sort of the root causes of that failure to thrive. Persistent pain and untreated diagnoses are definitely on that list. Under behavioral signs, restlessness, sort of the like, can't sit still, gotta get up, gotta move, gotta do this, gotta do that. That seems maybe not goal directed. That is a common manifestation of pain. Declining food, declining activity, even beloved hobbies. That is a pain behavior. And then repeated vocalization. So the help me, calling out for maybe spouses, caregivers, people, trusted people. That I was taught that is pain until proven otherwise. And I was a little skeptical of that at first. And then I saw it. And it is indeed pain until proven otherwise. History still really matters, even in cognitively and communication impaired patients. Remembering that older adults may not use the word pain. They may use other colloquialisms like ache or twinge or stitch. I used to hear that a lot when I lived in Little Rock. We also, beyond kind of the usual descriptors of like, what does it actually feel like? What are you going through? What's most important, I think, is determining the impact that this is having on the rest of their lives. How is this affecting your function? How is this affecting your social contact? How is this affecting your overall quality of life? And then collateral history. So people that are around the patient may have different experiences and different perceptions and may offer really, really valuable information. I feel like I'm preaching to the choir here, but don't discard those spouses, adult children, roommates, caregivers, long-term care staff. They always have useful information and they may not bring it up unless you ask. Again, always pursue a specific diagnosis. You may be in the very unique position of being some of the first people to recognize when a client or an older adult is suffering. And you may be some of the best coaches for those patients, but to help them navigate what can be a really complicated system, but also to help break down some of their own barriers that this is important. There are things that can help. And we want to help you kind of live your full life. This is a really nice scale for those who are objective scale people. This is one of the best ones out there for cognitively impaired patients. Basically takes all of those behavioral signs and grades them by severity. It has evidence basis for it, and a lot of long-term care facilities in our area are actually using this as their standard pain assessment that's mandated by Oregon state law. So you may actually see this in some records for long-term care dwellers that you work with. And so that's what this is. Don't discount those other signs of discomfort. I've sort of labeled them in my simple brain the negative behavioral signs, similar to like the negative signs of schizophrenia and other psychotic disorders. that social isolation and withdrawal, particularly from like trusted people, beloved activities, things like going to religious service, going to the beauty salon, get their hair done. Those can be real potent pain behaviors, pushing away food and fluids, and then even daytime sleepiness. Pain actively interferes with sleep quality. So these patients are commonly getting less REM sleep, which is the restorative part of sleep. And their brains, for folks in that situation, myself included, your brain will put you to sleep if it's in desperate need of REM sleep. And so that manifests as these patients napping, maybe a lot, or being too tired to go out and do things during the day. And that can be a compensation strategy for poor restorative sleep. Long story short, any behavioral change, anything that seems out of the ordinary for that person, that family members or trusted people are saying like, something's off, something weird is happening, that should prompt undertreated pain to be on the list of things that are happening. It may not be the explanation, but it should be on the list. Remember, you all are, I think, beautiful examples of the benefits of working in teams. I wish doctor types would take that lesson from all of you. Use your team, work your team for more observations, more data, more thoughts, especially for those people that are lucky enough to have multiple people in their orbit. For those who really like algorithms, who really like sort of step-by-step reminders of what to do, this is a really helpful one from some nursing experts at the University of Iowa. And it actually breaks out sort of step-by-step approaches to investigating pain for cognitively intact or verbally intact patients versus those that are cognitively and communication impaired. And so those, I know lots of people are algorithm people, and so this is a really nice, sort of easy stepwise approach. We're going to breeze through treatment considerations, but I do want to tackle this first part. So what is the goal? What are we shooting for when we're talking about treating particularly chronic pain? We're not talking about the complete elimination of pain. That, to achieve that, that's called death or general anesthesia. The treatment of chronic discomfort and chronic pain is, the goal is to maximize function, both physical function, social function, and cognitive function. It, of course, is to enhance comfort, but really we're shooting for a regimen or cocktail of things that will help the person function better in their lives. Part of the reason behind this is that there is no medication or combination of medications or even combination of medications and non-medication therapy that will completely eliminate chronic pain. We know this from lots and lots and lots of studies and expert advice out there over the last few decades. At most, from drug therapy, patients can expect about a 30% reduction in pain intensity. I recite, and I bring up this number a lot to patients of mine because I find it really helpful to level set expectations, particularly for folks that are really comfortable taking medications and maybe have had good results taking pills for other conditions, and maybe sort of veering towards like, well, can I take something for this? Or even family members that may have that belief. This is not the be all end all, only about a 30% reduction in volume of pain. I feel like this too is not going to be new information for this crowd, but especially amongst older adults and particularly cognitively impaired older adults, pain is a very, very common symptom of untreated mood and anxiety disorders. Depression, in particular, among older adults, is heavily skewed towards presenting with physical signs and symptoms. So instead of the like anhedonia, the low mood, the hopelessness, the worthlessness, the withdrawal, there are more older adults that actually present with the physical symptoms. So change in appetite, change in sleep, fatigue, and pain. And pain particularly that may have no organic source. That I know even when I have been through depression myself, pain was actually a big part of my symptomatology and syndrome. And it really was just sort of aching everywhere, muscle aches, joint aches, and just sort of feeling crappy. And older adults definitely experience that. Pain is also, among older adults, a reflector of persistent stress, interpersonal stress, relationship stress, interpersonal violence, which of course interrelationship violence, which older adults are not immune from, may reflect some unmet structural needs like food insecurity or marginal housing, and is definitely a driver for substance use, which older adults are also not insulated from. Pharmacokinetics and aging. Here's more details for those that might be interested, but the takeaway here is that older adults do not process medications the same way as younger adults do. Bodies are different. I don't know about you. Again, I just turned 40. My body is very different than it was when I was 25. That experience is just even more exaggerated when you are 75, and maybe when you're 75 with Parkinson's, or maybe 50 years old surviving a traumatic brain injury or stroke. That person's body just works differently. All of those patients are going to be more sensitive in particular ways to particular medications. And so certain medications become just out and out dangerous for this more vulnerable group of people. Others, you may actually get a real bang for your buck at really, really low doses. And not a lot of doctors and prescribers are really acutely aware of that. There is still a lot of education out there that like family practitioners, general internists, even specialists really could use about safe prescribing. Here are the rules that we follow, that we try to follow as prescribers. The two drug classes that are in here in the next slides. Again, I realize most of you are not prescribers, but you may be in the position of recognizing when something is going wrong that is medication related. The two classes that I bring up here are the muscle relaxants and the opioids. Muscle relaxants essentially don't use. They always cause problems for vulnerable adults, cognitively impaired older adults, even younger adults. And here are the common side effects: sedation, sleepiness, falls, very, very common. We see this a lot on the trauma service, headaches, blurry vision, and they can even be habit forming and cause some dependence. So they are still very commonly prescribed. Chances are you have seen some clients that have been regular users of muscle relaxants, and they can get people into trouble really quickly. Opioids. I realize I have come of age and been in practice and training during sort of the height of the opioid crisis. So I'm well aware that opioids have been way overused. The pendulum swung way too far. But what has happened in recent years is that, particularly for vulnerable groups, like the folks we're talking about, the pendulum actually has swung back really far in the other direction. And so it is actually really common for older adults and vulnerable adults that would benefit from maybe a teeny tiny dose of an opioid to have them withheld out of fear and risk, an appraisal of risk that is really not individual to that patient. And so we as geriatricians, for our patients, we always consider opioids still on the table. They're part of the toolbox, and they are appropriate for certain patients. There's still a lot of fear out there. You, chances are, have interacted with caregivers, other team members, even family members that have been really scared about opioids, even clients themselves about starting opioids for particular conditions, particularly after a surgery, after an injury. A judiciously dosed opioid, an appropriately managed opioid with support and with oversight of caregivers and care teams can actually help people recover physical and cognitive function faster after a calamity like a surgery or an injury. And so the answer here is not a hard no. The answer is it depends. if you see any of your patients taking tramadol, you may want to raise some concerns. Tramadol is very dangerous for vulnerable older adults. This is my favorite quote, favorite metaphor from a nephrologist about what tramadol is. And it really is accurate. We've seen a lot of tramadol cause a lot of problems. It is an opioid, first of all. Don't let anyone tell you it's not. But it's like the dirty bomb of opioids. It interacts with a ton of other medications. Patients that you all may be seeing that have complex mental health regimens, pharmacologic regimens, can really run into trouble with tramadol because tramadol hits a lot of those same receptors that those mental health meds are also trying to attack. So you can really get into some complicated side effect situations and drug interactions. It for a long time was thought to be safer than opioids, but there's actually really recent data that shows that it increases the risk of death amongst all adults, actually over the age of 18, by about 2 times compared to regular opioids. It also lowers the seizure threshold, so it makes people more vulnerable to having seizures, which is okay, maybe for folks who've never had seizures or don't have any risk factors, but for folks who have had seizures before, adding tramadol can actually increase the risk that they will have more seizures. Cannabis. Long story short, jury's still out. The use in older adults is increasing. Chances are you have clients or family members or people that you love that are either cannabis interested or cannabis using for symptoms or even basic things like to support sleep or address situational anxiety. But for vulnerable patients, cognitively impaired patients and older patients, we don't know what can happen. We also don't know effective doses. We don't know THC to CBD ratios. We don't know best routes of administration. Is it better to smoke it? Is it better to have edibles? Is it better to use topicals for certain conditions? Jury is just still out. So if people come and talk to you or express some interest about trying different cannabis formulations, I tell people the truth. I don't discourage anyone because I don't want to put up barriers to future conversations. I wouldn't want people to be afraid to come to me and say, I tried some cannabis and here's my experience. So I try to keep the door very open, and I just tell people the truth that we don't know. There are people that have gotten some good benefit, and there are others that have really struggled to find some benefit or run into a lot of side effects. And again, just keep the door open. And so if you've got patients that are really wanting to try, I don't discourage them, but I do say okay, go ahead. But I want you to follow up with me. I'm going to connect with you by phone or let's connect a week or so after you start, just to make sure that things are going okay, because lots of side effects can happen. We've actually seen falls from cannabis intoxication. Lots and lots of other symptoms can happen, even psychosis and confusion in older patients. So TBD, maybe we'll know more in 10 years or so. Here's sort of a common general approach for how primary care providers and ambulatory care providers will manage pain. This is what I practice by, and most of my colleagues practice by. So if this is a resource, a reference for you to just have some insight into what your clients' providers might be thinking or might be doing, even as something that you may want to slip to a provider and say, hey, I got this from a geriatrician, isn't this cool? And use some of your reverse psychology on some overworked primary care providers. Totally cool. PRN-based regimens, which means as needed. As needed regimens only work when patients are cognitively able to manage it themselves. Sometimes family members can do this very well. Long-term care, though, it doesn't work really well for a variety of licensing reasons and kind of red tape type reasons. For cognitively impaired patients that have reliable symptoms, that may be living in long-term care, it's actually easier for their prescribers to schedule a medication, even a short-acting opioid, for particular times of day that are known to be troublesome for that patient. And so this is a really, I think, useful suggestion that you in your roles as care coordinators, as navigators, social workers, therapists, you can bring this up. You can make this suggestion to prescribers. I know some doctors are very prickly and not always the nicest people, but most of us are getting better, I promise. And even if we're a little prickly at first, good ideas are good ideas, and they will take root. And if you can help benefit the patient, it's worth it. I want to touch on very briefly Tai Chi and massage, because these I think are really great interventions that you all in your roles are well positioned to bring up and discuss with patients. Tai Chi, this is ancient Chinese practice, actually, that dates back something like 4,000 or 5,000 years. And so in Eastern medicine, they have known all the ins and outs of Tai Chi benefits for a long time. Western medicine has finally caught up. And there is great data, some of which I've shown here. This is, again, another meta-analysis or a study of studies that pulled together all the data out there on Tai Chi for osteoarthritis, for low back pain, for osteoporosis and fibromyalgia. And what do you know? Tai Chi works for it all. The data that's out there is really expansive now. They've looked at effect across sexes, across decades of life, different racial groups, and even compared to aerobic exercise. And Tai Chi comes out on top for all of those people. You can adapt Tai Chi regimens to be done seated for those whose balance maybe is not great. You can start in a seated position, and then as patients, clients feel more confident, they can progress to standing. And this is widely available now. So there are almost every, I think, assisted living facility in the state of Oregon has access to Tai Chi classes in their buildings or within their complexes. Senior centers, community centers, parks and rec classes, martial arts studios, all sorts of places now are offering Tai Chi. And there are even classes that are free or on a sort of means tested sliding scale for people that may be on limited finances. So this is way, way, way more accessible than it used to be. A lot of those classes went away during COVID lockdowns, but they're back. So this is a really good time to get people connected again. The goal that we advise people for kind of best effect on pain in particular is 1 hour, 2 to 3 times a week. So it is a lot. But even if patients can do like 1 class a week, they may still get some benefit. And even if they learn some good practices, maybe they can do it on their own or with their caregiver in their facility. Maybe the better approach is a DVD or even streaming some Tai Chi's or sessions over YouTube. All of that counts. So there's no wrong way to do this. This is an evidence map looking at sort of the state of the evidence for Tai Chi. You can see it's been studied for just about everything. And I pointed the arrow to pain because we actually have a sort of satisfactory level of evidence showing that Tai Chi is beneficial for pain. It's also beneficial for falls, which is this green bubble here. And this is even more clear-cut than for pain. There's a ton of evidence that regular Tai Chi reduces the risk of falling. Massage. The data on massage is not quite as robust, but getting there. So this was a survey of older adults in Kentucky from just a few years ago. They actually had a large percent of the respondents were over the age of 75, completed a quality of life survey. And then the researchers broke it down by those that were regular massage users, meaning they had 1 massage within the prior year, versus those who had not. And here's what this graph shows. The black are those massage exposed or massage users. The gray are those non-users. And it is across the board. every potential outcome on the survey was notably better amongst those that reported having had a massage within the last year. And so this is exciting. There are, of course, limitations to studies like this, but this is, I think, exciting for the future. And when we even look at younger patients that are receiving regular massage for mostly musculoskeletal pain, and in this group, the average age was 42. This is another study of studies, and it favors massage. This little triangle here is the average of all the data. Massage works. Just like Tai Chi, there are actually more options now for medical massage on sort of sliding payment scales. And even for some of our dual eligibles, Medicare and Medicaid patients, MA plans, there may actually be some coverage for medical massage. Okay, when meds are misused, older adults are arguably at some of the greatest risk for this, in part because they are just exposed to a lot more pills than younger adults. But even chronically ill younger adults and those maybe that are just more vulnerable and more fragile in midlife and younger are also going to be vulnerable. Misuse is not the same thing as abuse. There is a difference here. The DSM-5 actually has sort of discriminated diagnoses there and categories for when it becomes a use disorder or substance abuse. Misuse is also not confusion about what to take. If someone is struggling with how to organize their medications, manage their medications, and of course they've made some wrong moves, doubling up doses or missing doses along the way, that is not considered medication misuse. That really is more a problem that is going to be more amenable to thinking about like better care management. Can we deliver meds in different ways? Would blister packs help? Would a med box help? Do we need occupational therapy? Those kinds of interventions. Older adults are at unique risk for a couple of big intersecting reasons. They are exposed to more prescription medications and even non-prescription supplements and over-the-counters. They generally have higher symptom burdens. Remember, a lot of these folks are living through events that may have ended their lives a few decades ago. So cancer survivors, heart disease survivors, stroke survivors, and so on and so on. And so they may be living with more discomforts, chronic nausea, fatigue, right? Lots of just symptom burden. And then, of course, older bodies are not younger bodies. So throwing more medicines at those symptoms, which of course we doctors are known to do, can actually end up creating drug-drug interactions, side effects, lots of chaos. Those that are at the highest risk among older adults for medication, true misuse and substance use disorders are those that are female identifying, those that are dealing with loneliness, more than just isolation. Loneliness is has been defined as the desire for more social contact and activity than they currently have. So a mismatch between what they already have and what they would like to have in their lives. Those dealing with depression, and of course those living with a prior substance use disorder. The most recent estimates is that this affects roughly 1 million older adults, and that's probably an undercount. I'm fond of teaching my students and teaching even other providers that I work with that we as human beings never get too old for sex, drugs, or rock and roll. And I mean that in all seriousness. And we see this when it comes to substance use disorder. The prevalence, so the number of older adults living with alcohol use disorder, opioid use disorder, sedative and benzo use disorder are rising in this country. And again, they're probably undercounts based on the most recent studies. There's a strong overlap with depression and even suicidality, even in older adults and vulnerable older adults. The other part of this that we don't often think about is that as folks age, more of them are going to be aging into their later years with a substance use disorder diagnosis that may be in remission. I am seeing more of this in our hospital. Folks that talk about having used heroin in their younger years and gone through rehab, sort of traditional 12-step, NA style rehab, and been in remission for a number of years. Now they're having medical issues, and we think or talk about opioid therapy, and it comes up that like, oh, well, is that going to cause me some problems because I have this history? And this is a hiccup and a hurdle that we're seeing more because we don't tend to ask older adults about maybe diagnoses or experiences that they've had when they were younger. And this arguably is a form of healthcare ageism, where we look at like sweet grandma or sweet grandpa and assume that they've never done anything wrong or bad in their lives. When really this group can definitely age into their later years with vulnerability to relapse, and then vulnerability to new diagnoses of substance use disorder. Managing pain alongside an established SUD is really challenging. There is no one right way to do this. What is falling into favor, particularly amongst those with opioid use disorder and legitimate, pain that needs to be pharmacologically treated, is using buprenorphine, even Suboxone, as sort of two birds, one stone therapy to manage the pain while also hopefully reduce the risk for cravings and all the sort of psychologic symptoms of SUD coming back up. We're seeing this a lot more even in older adults to sort of do double duty. I haven't seen any really great evidence about this yet. This is more just sort of practice, but maybe over the next 5, 10, 15 years, we'll know more about best practices here, what to do, how to handle these things. Talking with these patients really comes down to making decisions together, understanding who the person is, what's most important to them, what their values are, what their goals are, and trying to bring everyone together, prescribers, caregivers, the whole team, along with the patient and the client, to figure out what is going to be the regimen, even if it has some risk to it, that is going to maybe match what's best for this person at this stage in their life. And treatment planning. In this situation, when you've got complicated, vulnerable patients that are living with chronic pain, mental health conditions, cognitive or communication impairment, plus minus a substance use disorder, holy moly. As I was putting this talk together, the image that immediately popped into my mind was a tangled up ball of string, because in order to successfully treat these patients, you have to pull on all the different parts of the knot, right? You have to pull on all the different threads in order to make sure that everything is being attended to, almost like a juggler, keeping all the balls in the air. I imagine this is very preaching to the choir as well, but use all your tools, work your team, and work the systems, and make sure that we're paying attention to not just the physical needs, but also the mental health needs, the medical needs, the social needs, and even the environmental needs, in order to address and support the person so that they can better manage their symptoms and we can better balance treatment that may have some inherent risk to it. Success here also relies on communication and duplication and repetition. Setting clear function-based goals, right? Not just, I want to be pain-free, because we know that's either death or anesthesia. And making sure that any of these overlapping conditions, like mental health conditions, substance use conditions, other medical diagnoses that are going to require ongoing treatments, making sure that that client actually has regular follow-ups with the relevant specialists or providers for all of these intersecting conditions. And in an ideal world, those providers would be talking to each other about like, here's what I'm thinking, here's what I'm seeing, here's what I'm going to recommend, how is that going to impact you, right? Pulling on all the threads together. And then documentation. I find that repetition is actually really helpful. And I keep a very, very low threshold to fax, fax or even email my thoughts or my worries for consideration, even if they're not asked for proactively, to relevant team members, even if they don't read it, I know that I have done my part to try and create a system for the patient where the expectation is that we all talk to each other. I know my therapist complains about this a lot, but that she never gets responses from providers. But even if you don't get a response, it doesn't mean that provider didn't read it and pay attention. It may just be that they didn't respond. So keep hope alive, and then document, and repetition is your friend. And remember, this is really hard work. There are no easy answers. These patients do not fit easily into big studies. So we have very clear, idea of what to do and how to handle situations. Again, preaching to the choir, I imagine you all are very familiar with this kind of dynamic. Every situation is different, and the way at least I keep myself going, and my partners keep themselves going, is with every day caring for these vulnerable, complicated people is an opportunity for some creative thinking. It may, we may see new obstacles, the boulder may roll back down the hill, but maybe next time we can think of a new or creative way to get it back up the hill. And reminding myself that a good day for my patient is also a good day for me. I realize, wow, I have gone right up to the wire. I am happy to stay a few minutes over 9:30 if that works for you. I also understand you all have very busy days ahead of you. So I would love to hear your questions, your thoughts, worries, wonders, anything you got. Throw it at me.
That was excellent. Thank you. I know I have a question, but I
Please.
want to give the floor to some of my colleagues that may not have the same access as I do to you. Okay, do we still have APS on the line? Do we still have an APS representative? My question has to do with any adult, for whatever reason, that maybe is not in tune with pain. And we have a client right now, an options case managed client that is 80 years old, that had broken her arm and wasn't even aware of it.
Oh.
And I wonder, does that help us make the case for self-neglect, to be able to call APS and say, I think somebody needs to do safety checks. I think somebody needs to get in there and check this out. It's obviously much more complicated, but yeah, pain and building the case for self-neglect. For whatever reason, it could be that you've got somebody with schizophrenia, bipolar, that is not able or willing to take their medications. And so how do we restabilize when we see something that big? Like, I don't know, walking around with a gunshot wound, pain and self-neglect.
So my short answer to that is I think so. My longer answer to that is I love adult protective services, and I usually keep a very low threshold to call them if I have any sort of Scooby-Doo sense that something isn't right here. I know they are overworked even in Multnomah County, but I fall back on the horrific cases we have seen here at OHSU where maybe nobody called, and you kind of look back and wonder, what if even if APS didn't take action, but they referred to other services or found a way to do some routine safety checks, could the downstream negative consequences have been prevented? And so I, again, keep a pretty low threshold to even talk to the intake folks at APS. I'm sure they know me by name, and we love them. Your question more specifically, though, I think the short answer is yeah, maybe. I would want to ask some more questions first and get some more data, because that sort of insensitivity to pain, or not realizing that, like, wow, you have a pretty major injury there, that we do see that for sometimes weirdly legitimate medical reasons. There may be some other, legitimate medical reasons that the injury went unnoticed that really aren't due to true pathologic self-neglect. The way the Oregon statute too works is that APS really can't take action with an adult that is not cognitively impaired in some way. And that could be severe persistent mental illness, you know, the untreated schizophrenic patient that they're cognitively is just not aware of what is happening and even the basics of what they need to do for that. It could be the person with undiagnosed cognitive impairment and dementia still living in their home. That happens a lot. But for those folks that maybe, and I've had patients like this too, that were, the best way I had to categorize them were lone wolves, that maybe had the strong desire to like, I want to die in my house no matter how it comes. Had terrible injuries. I had one patient I'm thinking of in particular who was down in his house for 2 days when his neighbor found him. And at that point, he was still cogent enough to say, I do not want to go to the hospital. I want to die in my house. And his neighbor didn't know what to do. And she called 911 and he ended up in the hospital and he ended up dying here. There are those patients. And as we investigated with, you know, the people in his circle, he was not cognitively impaired. He was not depressed. This was just his desire. And it was a really awful situation. And my understanding from APS is that unless there is data, even objective assessment or worry that this person is incapable, that they cannot act. So
Fair
your
enough.
scenario about the woman with the unknown, unrecognized broken arm, we need to sort of flesh out like
Sure.
what's going on here.
Mm-hmm.
If there's other signs of self-neglect, you know, things like hoarding, moldy food in the fridge, I would use that all together with the fact that like she had an urgent condition that needed medical treatment and didn't get it, and is not feeding herself, is not cleaning the house, right? Make that sort of total case for self-neglect.
Thanks for that.
Yeah.
Great. Well, I think some folks have jumped off, and we really appreciate everyone attending the training.
I had a quick question.
Okay, go for it.
I'm not seeing so much pain as the biggest issue. It's people that have been on like benzos for like 30 years for their anxiety, and they're like 70, and I just don't really know what to do with them other than giving them some psychoeducation on how it's probably not effective. And I can't believe their doctor have continued that medication for that long. I just don't. Is there anything that you would recommend to do, or is it just kind of a no point at that point?
No, there is always a point. So that is a hill to die on. First takeaway. And Nico, like, you are not alone. We still see these patients all the time, and for some reason, there is a small subset that just defaults to like, you will pry these benzos out of my cold, dead hands. And I, you know, so again, I seek to understand, right? If they've been on a benzo for 30 years, there's probably a reason why. So all of those rules still apply. But don't be afraid of the conversation. And understand that it's a journey. You are almost completely unlikely to get that person to change their mind after 1 or 2 discussions. It's going to be like constantly having to push on that button. There are some really, really great resources from a group, the Canadian Deprescribing Network, out of Ontario or Quebec, I think, that actually did some really good randomized studies on deprescribing resources for benzo-using older adults. And folks, particularly these folks that were aging into their later years with a benzodiazepine. Great patient-facing material. I can send Angela's the link to this material. It's open source, it's free to use, PDFs, you print it off or send it to people. And it even, there's one that even has a taper calendar in there that patients can bring to their providers, and you know, when they're ready to taper off, to make it really easy. I tend to focus on using language that doesn't that avoids kind of making people feel bad for being older, that like you're too old for this. People don't like that. That's bad. Instead, what I like to say is that I'm glad this medicine worked for you. I'm glad. Like, look at, you've gotten some benefit from it. That's awesome. What we know, though, is that these medicines can work really well for people when they're 40, but once they get into their 60s and 70s, the machinery of their body is just not the same anymore. Right? So I kind of hit on that metabolism argument. And reinforce that by like, I don't know about you, I just turned 40, my body doesn't feel the same anymore. And instead make it the problem of the medication. It's not the client who's the problem. It's not the medication that's the problem. It's the fact that they're just at a different stage in their life now. And we need to think about things that may actually work better for them and prevent them from having something like a hip fracture. That always scares everyone at this age. So that's usually the scary consequence that I like to bring up, because that always, particularly for women at that age, is always like, oh God, I don't want to do that. Yeah, so that's the conversation that I try to frame. And then again, I don't blame. I try to keep the door open, understand that this is a journey, not a destination, and that we're in this together.
Thank you.
Yeah. Angela had asked me a while ago, because you are not the only person out there in the options and ACT world that is having benzo problems with their clients. So I actually have a session already made that I put together called Benzo Boondoggles that I would love if the Angelas can make room for me. I would love to talk benzos more with you guys.
I think we can find an hour for you.
Yay.
How long would you need? 1 hour, 2 hours?
Yeah, I think I'll have to go back and look. I think an
Okay.
hour and a half,
We'll
maybe.
figure it
Well,
out.
for discussion, yeah, maybe longer, a little longer is better.
Okay.
And will you have something in that and how to support people who've been taken off benzos? Because
Yeah.
I've worked with several adults now that doctors went, oh, let's get you off of these cold
Yeah.
turkey. And then they've ended
Oh,
up on
God.
psych wards multiple times.
Yep.
So
Yes, absolutely. And whenever I talk about deprescribing anything, actually, that's part of the deal. If you're going to take someone off a medication that may not be doing them any favors, you still have to think about and attend to the fact that that was treating something. And we need to pay attention in parallel to treating that underlying thing just in a better way.
thank you.
Thank
Yeah,
you.
of course.
Yes. Wow. Well, I wish we had another half hour to get in to dive a little deeper, but I know we don't. And we are going to have to say our goodbyes, but we've got some good ideas. And if anybody thinks of some questions after the fact, like, oh, darn, I wish I'd asked about this client, run it by me. I can get it to Dr. Drago. I can put you two together, you know, and step out of the middle so you can get your questions answered. I would love to dig deeper down the road into chronic mental illness, pain, manifestation. We really just gave you the Reader's Digest version today in the intro, so let's keep going forward. Folks, we're going to have to wrap it up. You're going to get everything. You're going to get the slides. You're going to get the CEU materials. We're going to need a little bit of info back from you to do that. Those of you that need CEUs, you know how this works. There's no getting out of this without a survey. It's just the way it is.
Your feedback also really helps me too. I read every comment, and if there are things that you wish you heard or things that I could do better, please don't hesitate.
Right, right. So give us your ideas, what else you want to hear. We'll try and make that happen for you. All right, go forth and conquer. Have a good one. Be kind to yourselves and each other. And